Thank you to everybody who's logging in. We'll get started in just a minute. We'll let people make sure we get them out of the waiting room and into the webinar. So give us just a minute to get started. Thank you everyone for being here today. I'm going to go ahead and get us started. I welcome you all to our Accord seminar. Today you're here to see Dr. Maren Olsen talk about factorial designs for optimizing intervention development. My name is Sarah Brewer. I'm the director of our education program here at Accords, and I welcome you all to our program seminar. So as we get started, I know many of you are probably familiar with Accords, but some of you may not be. Accords is supported by the University of Colorado School of Medicine and the Colorado Children's Hospital. It's a unique one-stop shop environment for faculty to conduct pragmatic research, receive various types of services and support for grants and projects, along with incredible mentorship, training, and education in health services research. Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes by providing some of these amazing supports that you see on your screen right now. I particularly want to highlight our strong methodological cores and programs led by national experts, and specifically our biostats and analytic core led by Katie Colburn. They have partnered with our education program to put on this series over the course of the 23-24 year. Let me share a little bit about some of our upcoming programs. So over the next month, this is our last program before the holiday break. And then as we come back in January, we have a few things available to folks. The first is our D&I Science Graduate Certificate Program, has an informational webinar for people who may be interested in learning more D&I science in the new year. We have the next in our shared decision-making seminar series. Dr. Ellen Lipstein from Cincinnati Children's will be here on campus as part of that series, January 10th. The next in this series on statistical issues in pragmatic research is January 22nd. And then we come back to the next two in both of those series. We have Mary Politi here on campus February 7th and Dr. Rochelle Musi February 26th. So if any of these topics interest you, please go ahead and mark your calendar or register for those. And then we'll point out that our Colorado Pragmatic Research and Health Conference registration is open. You can check out information about that conference at coppercon.com. You can register right there with the QR code, and we hope to see many of you at that primarily virtual conference June 5th, 6th, and 7th of next year. Now, before I introduce our speaker, I just want to go through a couple of housekeeping items. So the first is please use the chat or the Q&A, either one works fine. With any questions or comments you have throughout the talk today, we'd love to hear your engagement and we'll be monitoring that throughout, and we'll have time for Q&A at the end of the seminar. And then second, we'll ask as we get closer to the end that you complete our evaluation of today's seminar. It helps us to make sure that we are meeting all of your educational needs in health services research. Now today, this seminar is part of our series on statistical methods for pragmatic research. It is the fourth of 9 talks in our series, and today we welcome Dr. Maren Olsen. Dr. Maren Olsen is a professor in the Department of Biostats and in Bioinformatics at Duke University Medical Center and a biostatistician in the Durham VA Center for Innovation. Her research activities have primarily focused on collaborative statistical methodology in the field of health services research, including analysis of clustered and longitudinal data, study design for complex behavioral interventions, and 2-part models for semi-continuous longitudinal health data. Topics presented in this talk are motivated by a study designed to optimize a mindfulness intervention for patients discharged from the intensive care unit. So please join me in welcoming Dr. Maren Olsen today as she presents factorial designs for optimizing intervention development. Welcome, Dr. Olsen. We've got you muted. There we go.
Here we go. And I will move to share my screen then. Okay, my presentation mode, Sarah. Okay. Hi, everyone. First, thank you so much to Sarah, Jordan, Katie, and the Accords team for inviting me to participate in this series and for all the organization behind the scenes that you've done to make this happen. So as Sarah mentioned in her introduction, today we're going to be talking about optimizing interventions using factorial designs. And this work has been motivated by a study that I have been working on for several years now with Dr. Chris Cox. He's a critical care pulmonologist here at Duke, and a fellow statistician, John Gallus. So I want to acknowledge their input right from the beginning, because this is definitely a team science approach to this talk. And I have learned so much about factorial designs and the application of them by our collaboration together. So I'm going to be first talking a little bit about what is a factorial design and why to use a factorial design in this specific context. And then we're going to switch gears a little bit and talk specifically about what's known as the multi-phase optimization strategy. This is a term that was coined by Linda Collins, and we'll talk a little bit about the goals within this framework and how they contrast to, I think, probably what's more familiar to people in the audience, an efficacy randomized trial. And we're going to be focusing on the decision-making steps within this framework, and specifically kind of focusing on how the analysis strategy helps to guide those decision-making steps. And we'll also touch on a little bit about sample size estimation for these types of designs. Okay, so first, let's talk a little bit about the LIFT intervention. The LIFT intervention is a mindfulness training-based intervention. It was developed because Dr. Cox and his colleagues were observing that intensive care unit survivors were experiencing significant psychological distress post-discharge from the ICU and then post-discharge from the hospital. And whereas mindfulness training has been shown to improve psychological distress in various patient populations, this patient population was a little bit unique in that often people are coming from afar to go to be admitted to an intensive care unit. And then when they're discharged, they're kind of discharged to whatever care, whatever location they would regularly get. And so Dr. Cox and colleagues then adapted a mindfulness training to a self-directed mobile app called LIFT. This is a short intervention involving 4 weekly app-based sessions. And the sessions include audio-guided meditation, mindfulness skills, and everyday life. And we conducted a pilot study examining the Lyft mobile app intervention and found it to be feasible and acceptable. And the citation for the pilot study is at the bottom. So the intervention content was finalized. Felt good about kind of how that content was received, and saw some positive signals for improving psychological distress through the pilot study. However, there were a lot of additional questions about kind of intervention delivery, and these were informed by a variety of people interacting with the intervention. First, there was feedback from patients regarding convenience and personalization. The staff experience also kind of contributed to where's effort being used to deploy the intervention. In particular, there's a therapist that was heavily involved in numerous aspects of deploying the intervention. And both of these things then were directly applicable to kind of the broader reach of this mobile app and intervention, right? How did decisions about intervention delivery impact cost and scalability? So the research team then wanted to investigate kind of what package, what components of some different intervention delivery options might work best. So the three kind of delivery options that they were focused on was, first, how the Lyft intervention was being introduced to patients. Was it simply through the self-directed way in the app, or was it important for the therapist to call individually all the participants and introduce the intervention to them? There was also uncertainty about whether a standard or a high dose in terms of kind of the daily dose of the mindfulness skills was important. And then finally, the app was kind of monitoring symptoms, distress symptoms throughout the intervention period. And it was unknown whether or not it was better to be handling those symptoms in a self-directed way through the app, or should the therapist then intervene with a phone call. So when you have a situation where you have kind of multiple intervention components, it's actually much more efficient to be able to simultaneously evaluate these instead of conducting separate trials for each component. And that can be done using a factorial design. Factorial design is when there are multiple treatments and those treatments have at least two levels and the levels are crossed across patients when they're randomized. So let's take a look at this specific example here, where we have our three intervention delivery components and they each have two levels. And so this is called a 2 to the third or a 2 by 2 by 2 factorial design, which generates 8 experimental conditions. But the way that these experimental conditions are realized is through that half of the patients get each level of the three components, right? So we have 20 patients in each of the experimental conditions for a total of 160 patients. But you can see that for the comparison of the app versus the call, for the introductory method, we have 80 versus 80. For the standard versus high dose, we have 80 versus 80. And for the app or the phone call handling elevated symptoms, again, we have 80 versus 80. So with 160 participants, we're able to actually be looking at multiple ways of each of the levels for each of the components rather than 3 separate trials for each of the components. In addition, the factorial design is also going to allow us to understand how the different levels of the components work together or don't work together. And we'll get into some of that when we walk through an example. So there are numerous options for goals or hypotheses to be tested with a factorial design. However, in the context of intervention development, what our goal is to determine the component levels that optimize the clinical effect. So we want to understand which of the components are more beneficial when they're combined and which may be detrimental when they're combined. And so we're going to set up our analyses to answer these questions rather than the numerous other questions we could ask with a factorial design. And when we set up our analyses to answer a question about optimizing a clinical effect, we can do this in a really nice way using the MOST framework. Okay, so let's talk a little bit about the MOST framework. As I mentioned in the beginning, this framework was kind of spearheaded and coined by Dr. Linda Collins and colleagues. The book that I've cited here is actually a fantastic resource for learning about kind of the details about the framework in these studies. And a lot of the information that I have in the next several slides in my talk I've gotten from reading this book. So the multi-phase optimization strategy, that multi-phase is an important part of the word there, or an important part of the title, involves thinking about kind of what goes into releasing what Linda Collins and colleagues call an optimized intervention. And the three main phases involve preparation, pilot, which includes pilot and qualitative studies, an optimization phase, and then an evaluation phase or an efficacy study. And you can see that these phases can feed back to each other. We're going to be focusing today on this middle phase, the optimization phase, in which she proposes using factorial designs to optimize interventions. And there's kind of two main principles involving the MOST framework. The first is the continual optimization principle, in which she states that optimization is a process moving toward an ever better intervention. And then the second is the resource management principle, in that an investigator using MOST must strive to make the best and most efficient use of available resources when obtaining scientific information. And those two principles are kind of what drives some of these feedback loops, with the idea that one isn't going to be moving forward with releasing an intervention until it has been optimized and also confirmed to be effective using an efficacy study. Before we get into the MOST framework decision making, I just want to pause briefly and kind of review what I think everyone is probably familiar with, but decision making around an efficacy trial. So as an example, we can take our lift intervention and think about framing conducting a two-arm trial where patients are either randomized to lift or randomized to usual care. And our hypothesis would be that patients randomized to lift would have decreased psychological distress symptoms at 1 month post-discharge compared to patients randomized to usual care. And with this design, a two-arm randomized controlled trial, we would be setting up a hypothesis test comparing psychological distress symptoms at 1 month between our lift and our usual care arms, and we would have a clear decision about whether or not lift was statistically improved psychological distress versus usual care or not. right? So we've kind of got a clear design, clear hypothesis test, clear decision with our efficacy trial. Okay, in the MOST framework, the decision-making process involves a number of potential different steps. I'm going to outline kind of a general decision-making process that I think echoes what Linda Collins and colleagues have presented in their book and what I've used in our LIFT trial. But keep in mind that there are a lot of different ways to kind of think about a decision-making process. The important kind of goal, though, is to make sure that that decision-making process is specified ahead of time. So remember, right, with this overall framework, that our goal is to determine component levels that optimize a clinical effect. I haven't actually defined optimize yet. We'll be getting to that. So the general steps in this process are, first, as I said, we're going to define a criteria for a clinically important effect of an intervention component. We can't optimize without knowing exactly kind of what our definition of optimizing should be. And then we're going to be fitting a model based on our factorial design, and we're going to use the estimates from this model to identify important components. And the important components will be those where the effects meet a clinically important criteria when the components are set at the high level. And if the effects do not meet the criteria, then they will remain at the low level. And then the third step then is that we will be kind of confirming our findings, confirming our choices of high and low levels of the intervention components with secondary outcomes, qualitative feedback, etc. And a lot of this can be kind of up to the investigator team, and again, should be specified ahead of time. And at the end, we will then have an optimized intervention. So let's circle back to the LIFT study design. Okay, so as I mentioned earlier, we conducted, we're actually just have finished wrapping up conducting a 2x2x2 factorial design. Now, even though it's a factorial design, how kind of the study operations look is they actually look like an 8-group randomized controlled trial, right? So patients are equally randomized to one of 8 groups after they've completed baseline. And these 8 groups are defined by the high and low levels of each of our intervention delivery components. And then their followed up assessments are at 1 and 3 months. And I just included down here at the bottom of the slide a citation for our protocol paper that describes the overview and rationale for this factorial design. Okay, so let's start to walk through the decision-making steps based on the LIFT study. So as I said, the first step is to define a criteria for a clinically important effect of an intervention component. So for the purpose of the talk today, we're going to be defining this as the PHQ-9 scale being our primary outcome at 1 month. And we're looking to see if the difference between the low and high intervention component levels is at least 2 points. And it's important for each of our components to define what is the low level and what is the high level. For our introduction method, app, delivering the introduction via the app is the low level, therapist calls a high level. Standard dose is the low level, high dose is the high level. Elevated symptoms being handled with the app. is the low level, and being handled with a therapist call is the high level. Okay. So the second step, right, then is to identify important components via a model. So let's kind of spend a little bit of time on this slide where what we've done here is specify a model that's aligned kind of with our factorial design and our decision-making framework. Now, recall 2 slides earlier, I showed that the study operations for LIFT kind of look like we're running an 8-group randomized controlled trial. However, we're not going to be setting up our analysis as an 8-group randomized trial. Instead, we're going to set up our analysis to focus on kind of how each of those intervention delivery components work on by themselves and in conjunction with the others. So how we've set up the coding in our model is that there are 3 main effects for each of the intervention components, where we've denoted C1 as the intro method, C2 as dose, and C3 as elevated symptoms. We've also included all 3 two-way interactions between the intervention components and the 3-way interaction. Another kind of specific point to make with setting up our model for optimizing intervention development is that we actually, instead of dummy coding the variables in this model, we effect code them, where the low level is coded as -1 and the high level is coded as 1 for each of the components. And by doing this, when we have a balanced design, which we do in LIFT, where it showed you that patients are being equally randomized to each of the levels, this makes it so that our tests of our main effects and our interactions are uncorrelated. Okay, so let's kind of walk through then an illustration of what some results might look like if we fit this model to PHQ-9 at 1 month, being our outcome variable. So recall, right, that our model has 3 main effects, 3 two-way interactions, and 1 3-way interaction. So in our kind of decision-making paradigm, the first thing that we're going to do is look at our main effects. Okay, and remember that our criteria was a difference of at least 2 points on the PHQ-9 scale between the high and the low levels. In this case, for the PHQ-9, a negative value is better, right? That indicates lower distress. So we can see that for intro method, our mean estimate is 0.6, does not meet our criteria. And so we choose then to keep intro method at our low level, which is the app delivering the introduction. Our second main effect is of dose, and we can see that dose, because our mean estimate here is -3.8, which is greater than our criteria of 2 points, it does meet the high, it does meet criteria, and that gives us evidence that we should choose to set dose to be at the high level. And then our third main effect is elevated symptoms. Again, that also meets the criteria. And so that provides evidence that we will be setting our elevated symptoms intervention component to the high level, i.e. that a therapist call will be handling the situation when there's elevated symptoms. But we don't stop there. The next step is then to look at the interactions to see if the interactions support our decision of dose and elevated symptoms being at the high level, intro method being at the low level. So the intro by dose interaction does not meet our criteria. And so we move on from there. Our next two interactions of intro by symptoms and dose by symptoms do meet our criteria. And we'll spend the next couple of slides talking about that, those two interactions. And then our three-way interaction does not meet the criteria, so we can set that aside right now. Okay, so let's first look at our dose by symptom interaction. Interactions are always tricky to interpret, and I would highly recommend, and Linda Collins in her book also recommends, that the first step to understanding an interaction is to plot the estimated means for each level of the two-way interaction. So that's what I've done here, and let's kind of walk through what this looks like. On the y-axis, I have the PHQ-9 score at 1 month, and recall that lower scores indicate less distress. On the x-axis, on the left side, I have the standard dose, and on the right side, I have high dose. And the orange line represents the intervention level when elevated symptoms are handled with therapist phone call, and the gray line represents when elevated symptoms are handled with the app. And we can see that that the lowest PHQ-9 is when dose is high and the symptoms are handled with a therapist phone call. This is what's called a synergistic interaction. When both of the components are set at the high level, they work even more together to produce kind of the desired clinical effect. Okay. Now let's take a close look at the intro by symptom interaction, which that mean estimate was 5.6. And again, we've plotted the estimated means for each level of this two-way interaction. On the left side, I have intro method being the app, and on the right side, the intro method being therapist phone call. Again, the orange line represents when the elevated symptoms are being handled with a therapist phone call, and the gray line is when the elevated symptoms are being handled with the app. And we can see here that when both the intro call and the symptoms are set to their high level, we actually have increased PHQ-9, which is why this interaction term is positive and not negative. And this is known as an antagonistic interaction, right? The high level of these two components together do not result in decreased symptoms. Instead, they result in increased psychological distress symptoms. Okay. So the results from both our main effects and our interaction in this example align and suggest to us that that the effect not meeting the criteria at the low level is the intro method, and that we should set that to the app, and that the effects meeting the clinical criteria for the high level are dose and elevated symptoms. We would then take this kind of combination of our optimized intervention, right, and confirm that these effects also have similar, lead to similar outcomes with our secondary outcomes, that there's nothing related to qualitative feedback that might lead us to reconsider this as our optimized intervention. And then we would conclude, okay, everything is aligned across all of our confirmatory analysis. We might also look at like longer term analyses too. We've got the 3-month We want to confirm that kind of everything stays optimized with this intervention component package, and then claim that we have our optimized intervention. And if we recall, right, that our next step in the MOST framework then would be to conduct an efficacy study where this optimized intervention is our intervention, and we would do kind of a standard randomized control trial where we would compare this to a usual care or attention control, depending upon what makes the most sense for the science. Okay, I want to shift gears a little bit before we start to wrap up to think about sample size considerations under this decision-making framework. So if we go back to the model, right, the analysis model for how we're conducting our testing should always align with kind of how we're thinking about sample size estimation. And with the effect coding, right, recall that our effects are independent. And so what I have seen, and what I think is probably one of the most simple ways to think about doing sample size calculations is where our hypothesis test of interest is detecting the mean difference between levels of the main effect. And that's exactly kind of how we set up our clinical decision-making criteria for the LIFT example. And I just want to point out that one nuance to using the effect coding is that when we take a difference of means, that this actually translates into 2 times the regression coefficient. So you just have to be really careful to know that your regression coefficient needs to be multiplied to translate it into the mean difference metric. And because the effects are independent in our model, we can actually simply do a calculation, for example, based on like a 2-sample t-test. But keep in mind, though, that the sample size that we're getting is not a sample size for each experimental condition. It's the sample size of the number randomized to each level of the main effect. And so because that's what our hypothesis is, and that then corresponds to, say, in this example where we have a total of 160 participants, we would be doing a sample size calculation or power calculation based on 80 versus 80 for a main effect comparison. Now, it's easy, just as with any other randomized trial, to get more complex with study designs. You can be looking at optimizing interventions in a longitudinal data. You could be looking at optimizing interventions in cluster data, and you may need to account for those correlations. There are a couple of kind of most specific software options, and I've put links for those here in the talk. There's also a really nice paper by Linda Collins and colleagues that talks about kind of group-based designs and sample size calculation methods for group-based designs. And then also, of course, when you have more complicated designs, say clustered non-continuous outcomes, or you're looking at longitudinal data with 3 or more time points, you can always, set up your empirical, you can always set up a simulation study to get empirical power calculations. Okay, before I wrap up, I just want to point out a couple of other kind of more recent papers, which I think have some really interesting presentations and discussion about the optimizing an intervention within the MOST framework. The first is this paper by Huffman et al., where, like the LIFT study, this study team was interested in three factors, each had 2 levels, where the primary outcome was continuous, so it was physical activity at 16 weeks. This paper, actually, they ran into a lot of challenges in kind of following all of the phases of the MOST framework, and where they had to kind of circle back, and they did kind of have to go through a continuum of loops in that kind of optimization principle steps. And I just think the discussion that they have is really interesting and really well written. I also wanted to point out this other recent example by Spring et al., where they're looking at kind of obesity, an obesity study intervention components. In this particular study, they actually had 5 factors that they were manipulating. So that resulted in 32 experimental conditions. Again, continuous outcome, primary outcome of weight loss from baseline to 6 months. And this is a really interesting summary and study, because their decision-making process is a little bit different than the decision-making process that I presented, because they really focus on higher order interactions, right? You can, they have 3, 4, 5-way interactions of the conditions in their model. And in particular, they're looking at the per person cost to what those different components together kind of combined, what they cost, and then only would be examining levels of components that met or were less than a specific kind of per person cost. So it's a really interesting discussion and shows a different way to think about a decision-making paradigm to come up with an optimized intervention. Okay, so in summary, hopefully I've kind of illustrated a little bit about how MOST provides a framework for this decision-making process, and that the objective is distinct, different than a randomized control trial for efficacy. Instead, right, our goal is still to be conducting a randomized control trial, and it's important that that trial is randomized and balanced, with the goal then to optimize the levels of the intervention components. There's other parts that go into the considerations about decision-making, cost, feasibility, potentially stakeholder feedback. This is actually, not surprisingly, an ongoing area of statistical research. And both of the papers that I've cited here have a nice discussion about next steps, where some research is happening. And the second paper here actually presents a different way to kind of think about decision-making or different criteria to be making decisions within the framework. I want to kind of point out a few challenges that I think are definitely relevant. One is, of course, that, you know, following this multi-phase process does involve getting funding for an interim step of conducting this optimization trial. I do think that funding agencies are interested in kind of innovative designs like a MOST, SMART, et cetera, that can help optimize kind of treatment regimes. And hopefully the overall goal then is that by the time you roll it out to an efficacy study, you're then not wasting effort and resources testing an intervention that isn't optimized in the first place. The other thing that I am actually kind of experiencing right now as we're writing up our main paper for our LIFT study is how to kind of present tables, consort, everything that you're maybe familiar with doing for publication for a standard randomized controlled trial. We have different, it's a different goal when you have a factorial design and you, again, are trying to communicate how you're screening components in and out and making decisions about levels of components. It's just a different thing that I think readers are probably not familiar with reading. And so we've been struggling with just our writing of this paper and hoping to make it as clear as possible to our readers. Interestingly, actually, the consort guidelines actually just were recently updated for factorial designs, although not specifically for factorial designs designed for optimization. I still think those guidelines are really helpful. And that is all I have today. And I'm looking forward to questions and discussion. Thank you.
Thank you so much. I've heard of most trials before. I've seen a little bit on them and I just learned so much. So thank you so much. I
Should
am
I go
gonna
ahead and stop share?
up to you.
Okay, I'll leave it open in case I need to go back to a slide, and then if not, I'll happy to close it. So,
well, actually, then I will start with a question that maybe helped with one of your slides. So Michelle asked, when you set your criteria, in this case, the difference of 2 points, and you're trying to identify whether those meet your criteria when you've done run your model, are you also looking for the confidence interval to exclude that clinical value? Or is it okay if that confidence interval includes your 2-point PHQ-9 difference? So I'm curious if you can
yeah, I
think a
will.
little bit to how you make that decision.
Yeah, I think what we're using the 2 points for, of course, coming up with those 2 points is always, I fictionalized it here, but that in general, this involves like a number of conversations with the PI and the research team to kind of understand what is clinically meaningful, like in terms of an improved effect, right? And I think you want to, first of all, you want to think about setting this criteria as, okay, I'm going from a low, less resource intensive level of an intervention to a high resource level of an intervention. Like, what do I need? What kind of shift do I need to see on my primary outcome to justify that extra resource, that intensiveness of the intervention? And so in this case, 2 points is like, I would consider that a minimum criteria. And so in our first example, or in our first main effect here of dose, right, we have that the mean difference is 3.8, which is considerably greater than 2. And in fact, our confidence interval in this fictional example doesn't even include 2, but that isn't really part of our criteria. What we're really looking at here is that the mean estimate is at least 2. And we might also choose a criteria that we also want it to be statistically significant, and that our confidence interval doesn't include 0. But we're not usually looking at whether or not the confidence interval includes the criteria.
Great, thank you for explaining that.
Okay.
We have another question about the feasibility and the number of conditions you end up with in your experiment. So Jen asked if it's not feasible to test one of the conditions, or if the number of conditions is just too large to test all of them. Is that still a factorial design? Are there ways to make those decisions? And the example she gave was if, for example, high in all 3 of your main components was just an unfeasible intervention, would you include that?
Oh, yeah. I think you can have, I guess I would maybe answer that in 2 different ways. technically, there are designs called fractional factorial designs that allow you to kind of have partial, not have a full factorial where everyone is getting, where all conditions are kind of are allowed to happen. But I would say conceptually, I would kind of argue against thinking about intervention levels that wouldn't all be feasible together. And I would be really kind of rethinking about the components that you want to study to make sure that in combination that would be something feasible. You know, a lot of hard work and hard thinking goes into to choosing these components, to narrowing them down to 2 levels, for example, rather than having them be multiple levels. The other thing that I think is really important too, when you're thinking about the intervention components, is you want them to be components that you as an intervention team are manipulating, right? That you have control over, rather than what is the participant doing with something. So.
Great. Danielle asked about dropouts or loss to follow-up. So if you have differential dropout or loss to follow-up across your experimental conditions, how do you handle that?
I mean, so it's handled just like you would any kind of standard randomized control trial, that you first hope to prevent it in the first place, right? If you have, and you know, for example, the model that I presented here, right? I'm just kind of presenting a generic model with a cross-sectional outcome and you know, main effects like a regression model. But for example, in the LIFT study, we would be doing a random effects model. All of these are interacted with time, and we have the properties of how missing data is handled under a mixed effects model. But the other important point I think to consider that's distinct from a randomized control trial efficacy study, I mean, and dropout, is that we have this issue of that under a balanced design, i.e. that the sample sizes are equal in all of our experimental conditions, leads to tests of main effects and interactions that are uncorrelated. In practice, right, because of dropout or other things, this is rarely met, that you have the exact number. But if it ends up being pretty close, then those effects still are pretty much uncorrelated. So if they are not, right, if you have like hugely differential dropout with one level of your component, I would be really thinking about you know, kind of the feasibility of that component, and thinking about actually if that should be retained as an important component in the model or not. So.
You get some praise from your colleague, Dr. Cox.
Oh, okay, great. I wasn't sure if Chris was coming on. Great.
So we have a question from Evelyn. I participated in one study that developed an intervention to prevent HIV. They have data from 2 different populations, Blacks and Hispanics, modality, online and in person, and language, English or Spanish. Could we use this design to optimize the intervention, or what other things should we consider?
Okay, so I think that I heard that there was that. Okay, can you just repeat the 3 factors again? Because one of them is in particular giving me pause. So go ahead.
Yeah. So
Okay.
It sounds like they have data from 2 different populations, so Blacks and Hispanics, the modality of delivery, so online or in person, and then the language of delivery, English or Spanish. I'm curiosity if those are the kinds of components that they might be able to use to design to optimize.
Yeah. The short answer is no. Um, and but let me kind of explain that a little bit. The first rate, the race of the participant, that is not something that the study team can be manipulating, right? So you want your intervention components to be things that the study team, that you as the study team, and how you're delivering the intervention or how you're kind of packaging the intervention together can have control over. And so modality definitely seems like a criteria or a component that would fit that criteria. Language, I'm again not totally sure about that, because I don't know if that means that, like, would you then require that all participants be right to have equipoise, right? All participants would then have to be able to be randomized to receive the intervention in either Spanish or English, and there would be equipoise with receiving that. And so that would maybe only make sense if you were enrolling participants that were bilingual, who could, be able to, to understand the intervention in both languages. So of those three, I would say that the modality, yes, definitely not race, and possibly language, but only in a specific situation.
Yeah.
I hope that maybe helps a little bit to clarify. So.
Yes, and I think this next question is in a similar vein. Just thinking about the components that that you're testing, does the optimization components, do they have to be related to dose, for example, low or high? Or can you test the presence of a particular component, so an on-off switch?
Yes, you can definitely kind of test the presence on off, and keeping in mind that, that off is like your low level and on is that the level is there. And so sometimes, so I can give an example. And I think Linda Collins has this in her book, where an example of on off is in maybe a diet study where participants are randomized to either receive motivational text messages or not. And so the intervention component is, when it's off, they don't receive any text messages, and then when it's on, they receive these motivational text messages.
Thank you all so much. Thank you, Dr. Olsen, for spending time walking through this in such an understandable way. And thank you to all of our attendees. For those of you who are on, we'd love for you to fill out our evaluation. Jordan has just dropped it in the chat again, but we'd love to hear what you think. And Dr. Olsen, thank you so much again for sharing this example study and walking through this optimization strategy.
Sure. Have a great afternoon, everyone.
Yeah. Thank you, everyone.
Okay. Thank you.